All right, continuing on here in chapter 6. So talking about bone growth, right? So the length occurs at, again, that epiphyseal plate. There's actually 5 zones of that plate, and it involves the formation of new cartilage by that interstitial cartilage growth, also that appositional growth on the surface of the cartilage. So we have the closure of that epiphyseal plate. It becomes ossified, becoming the line between 12 and 25 years of age. So it does vary. So like we have growth spurts and when do you reach your maximum height and all that. Well, it depends on the ossification of that plate and when it happens. Again, that articular cartilage, it does not ossify, it does not become hardened, but it persists throughout life. The appositional growth only here, so that interstitial growth cannot occur because the matrix has become solid. So it occurs on old bone and or the cartilage surface is where that's going to happen. So these zones of the plate, so we have the resting cartilage, and we have a picture coming up. These are slowly dividing chondrocytes. Then the zone of proliferation, so it's like proliferating or growing. This is the new cartilage produced on the epiphyseal side of the plate as the chondrocytes divide. Then the hypertrophy, so we think about it shrinking. So this is as the chondrocytes mature and actually enlarge. Then we have the calcification. The name implies it becomes calcified and the chondrocytes actually die. And then we actually end with that ossified bone. And this is the cartilage on the diphyseal side of the plate is replaced by the bone. So just looking here at the plate, and again, we have our zones that are shown here. So on that epiphyseal side, then we have the diphyseal side. So again, whether we're close to the shaft or to the end, the epiphyse there on the end. So we have that zone of resting cartilage that's out on the end of the bone. Then the proliferation, hypertrophy, where it's enlarging, then that calcification, and then ossified bone all the way on the inside. Now the growth of that articular cartilage, the epiphyse, increases in size due to the growth of that articular cartilage. So that's what makes the ends be larger or smaller. That increases the size of the bones with no epiphyse, so like the short bones. So the articular cartilage will help the whole bone of a short bone grow. So then the chondrocytes that are near the surface, they're similar to those in the zone of the resting cartilage, so all the way on the outside. And then the articular cartilage, again, that persists through life and does not become ossified, as we mentioned. So what about the bone growth and width? So how wide or how thick a bone is, not how long, which is based on the articular cartilage. So the bone width is one of the most crucial factors in its strength. So not how long it is, but how thick or how wide it is. So the osteoblasts from that periosteum lay down bone under the periosteum and then gradually increase in the amount of bone surrounding that medullary cavity, which is the opening in the middle. Then the osteoclasts that are breaking down things form the endosteum. They reabsorb the bone surrounding the medullary cavity, and ultimately that cavity enlarges over time as those clasts start kind of deteriorating away what's there at the middle. So again, we have our periosteum here, the medullary cavity, compact bone there. So again, those osteoclasts are reabsorbing this bone as the osteoblasts are laying down new bone on the outside. So kind of like a tree in a way. So if we have a hollow tree, again, it's kind of dying from the inside, but only as new rings or new bone is being laid down. Now, what are some factors that affect bone growth? So the size and shape are mainly genetic, but can be modified based on nutrition and hormones. So the lack of calcium, protein, and other nutrients definitely causes bones to be smaller, especially vitamin D and vitamin C. So vitamin D we typically think about with calcium, which makes sense. But vitamin D is necessary for the absorption of calcium. So you can have lots and lots of calcium, but if you don't have vitamin D, very little gets absorbed. So it can be ingested and or manufactured by the body. So rickets, though, is a condition due to a lack of vitamin D during childhood, leads to kind of smaller bones that kind of bow out. And then osteomalacia, this is a lack of vitamin D during adulthood that causes bones to become softened. Now, vitamin C, it's necessary for the collagen synthesis that occurs from those osteoblasts. And scurvy is a condition, especially was common among pirates back in the day because they were on the boats and they didn't have their vegetable or their fruits or vegetables. And it's a deficiency in that vitamin C. And a lack of vitamin C causes wounds to not heal, property bones to fall out because, again, that collagen isn't being produced. Now, what about the hormones? So growth hormones, definitely as the name implies there, that's released from the anterior pituitary. And what it does is it stimulates the interstitial cartilage growth and appositional bone growth. Then the thyroid hormone is required for growth of all of our tissues, regardless whether it's bone or whatever. And then reproductive hormones like estrogen and testosterone. So that, of course, causes growth during puberty, but also causes the closure of that epiphyseal plate and the cessation of growth whenever it ossifies into the line. Just a couple things here related to growth hormones. So we've got gigantism, so it's excessive growth hormone during growing years, and then dwarfism is insufficient growth hormone during those growing years. Now, what about bone remodeling? So this converts that woven bone into the lamellar bone. So it's involved in the bone growth. It can also change the shape of a bone, and it makes adjustments due to stress, bone repair if we break something, and then also the regulation of calcium. Now, the long bones have two mechanical advantages. That hollow cylinder, that medullary cavity, is lighter in weight than a solid rod. So being empty in the middle makes it lighter. Also, that cylinder with the same height, weight, and composition as a solid rod, but with a greater diameter, can support more weight without bending. So the diameter, again, causes the bone to be stronger. So the relative thickness of the bone changes as the bone grows. So it constantly is removed by those osteoclasts, and then the new bone being formed by the blasts. And that medullary cavity increases the size to keep the bones from becoming too heavy. Otherwise, if it just kept adding on and adding on, it's going to be too hard for the skeletal system to be able to support. So it's important that those clasts are breaking down the bone that was initially laid down to make that cavity much larger to keep it light. Now, this is caused by what's called the migration of basic multicellular units, BMUs. This is temporary groups of osteoclast and blast that remodel bones. So they remove old bone matrix and replace it with the new. The lifespan is about 6 months for each unit, and it renews the entire skeleton every 10 years. So just to kind of put that in perspective of how active it is. So the formation of new osteons, the functional unit of the compact bone there, those osteoclasts enter the osteons from the blood in the central canal, and they can also move internally through the lamellae, and then the osteoblast replace the bone. Now, osteoclasts also remove bone from the exterior, and the bone is going to be rebuilt. This is just kind of showing some of that. So as we look here at this growing bone here compared to the adult bone, so some of the changes, again, the articular cartilage stays on the outside of the epiphysis, determines how long it's going to be, but never completely ossifies. So it gets a little thinner, but doesn't completely ossify. So that epiphyseal growth here, the growth of that cartilage that surrounds it, so that articular cartilage, again, it's mainly replaced by bone, but there is going to remain some amount on the outside throughout adulthood. Again, here's kind of where that bone remodeling is happening. So the length, the growth and length of that cartilage within that epiphyseal plate that ultimately becomes the line there. Now this cartilage here gets replaced by bone as it gets older. So again, here it's completely ossified inside. So we have bone being reabsorbed. So as it's growing out and we're laying down more and more bone, the osteoclasts come along and remove this so that we have that bigger cavity that's there and our bones don't get too heavy. Now, what about mechanical stress and bone strength? So increased stress actually causes bones to increase in strength. So the more stress we put on our bones, the stronger they become. And that's because of that remodeling. That's what kind of activates it, causes the formation of additional bone, and it alters the trabeculae, that part of the spongy bone, to align with the stress. Now, reduced stress results in more osteoclast breaking down the bone, which is going to cause weaker bones than stronger. And here we're not talking about stress like you're stressed out, like mental stress. We're talking about like exercise and moving. So that puts weight and adds stress. That's the type of stress that we're talking about here, is exercise and movement is the stress that increases bone strength. All right, so what about bone fractures and how they're repaired? So a few different types. So the mechanism of fracture is one of the classifications. So is it a traumatic fracture? Is it based on disease or the location of an implant? There can be soft tissue damage, and we have closed versus open. Displacement or non-displacement are terms we use to talk about fractures. The patterns that we'll see a picture coming up, is it linear, spiral, avulsion, stress, or compression? Also the number of fragments in the fractured bone. So is it incomplete? Is it complete or comminated? Sorry. And then we also have age specific. So if it's when we're young, it's called a green stick during that growing bone, or epiphyseal fractures that can occur as well. All right, so just looking at some of these, so a linear fracture, as the name implies, it forms a line along, kind of parallel with the diaphysis. Here's a complete fracture where it completely goes all the way across the bone. Incomplete, again, the fracture penetrates some of the diaphysis but doesn't completely go across it. Then the commuted is where it breaks into a bunch of different pieces, which would be the worst case scenario. And then transverse just means it completely goes horizontally across instead of kind of at an angle that we see here. It's a complete, again, transverse is also complete. It just indicates it's a straight line. Then we have the impacted type, again, where these are coming together and that impact is causing fractures. A spiral fracture is more that at an angle. Oblique would be one kind of at an angle, but again, an incomplete fracture. So then what about the repair system that comes in place whenever we have those? So there's first of all, the formation of a hematoma. So this is a mass of blood. We can think about like a blood blister or a bruise or something, but this mass of blood is released by the vessels, but confined within the organ or space. So it causes a clot to form and the bone tissue dies. Then the callus is formed, and that's just a mass of tissue that forms there at the fracture site and connects the broken ends of the bone. Then the internal, the blood vessels grow into the clot and the hematoma. Those macrophages of the immune system come along and clean up any debris, get rid of kind of the waste. Osteoclasts break down the dead tissue there. Fibroblasts start making collagen. Chondroblasts from that osteochondral progenitor, again, those stem cells of the perosteum and the endosteum produce the cartilage within the collagen. And then the osteoblasts invade and new bone is formed. Now on the external, the color around the opposing ends, the peristeal, again, progenitor cells become osteoblasts and chondroblasts, and then our bone and cartilage color stabilizes the two pieces. Now that callus ossification, now that callus that was formed is replaced by woven spongy bone, Then we get some of the remodeling, where we get replacement of the spongy bone with compact bone, and then sculpting of the site can occur with those osteoclasts. So just kind of looking at this again, our hematoma, just a bunch of blood floods the area. Then we get the formation of that callus, so the blood kind of just gets replaced by the callus as those fibroblasts and chondroblasts are activated. Again, here we're getting that woven bone that occurs. That callus is then kind of replaced and made into spongy bone, so it ossifies using those osteoblasts. And then we get some bone remodeling that essentially sculpts it. So it's going to get away from the spongy bone here. It ossifies it into compact bone, and then the osteoclast would eat away here at the middle to complete that medullary cavity. Now, what about calcium homeostasis? So again, one of the other functions of the skeletal system is regulating calcium. So again, bones are the major site of calcium storage. So the level of calcium depends on the movement of calcium in and out of the bone. So it enters the bone when osteoblasts, again, that are building the bone, creates new bone. The calcium leaves the bone when the osteoclasts break it down, which makes sense. If we need to build blood or build bones, we need calcium, so it comes in. If it's breaking down bone and reabsorbing it, it's releasing that calcium that was stored in that bone. Now, why do we need all this calcium? So it stimulates contractions of our muscles so that we can move. It also stimulates and regulates cardiac muscle contractions, so not just involuntary, or not just voluntary movement, but involuntary. And then also exocytosis of cellular molecules, so releasing things during signaling, so like releasing neurotransmitters like dopamine and acetylcholine. It's an influx of calcium that causes that release. So how do we regulate the calcium levels? There are three main hormones involved: the parathyroid, calcitrol, which is essentially the active form of vitamin D, and then calcitonin. So if we're looking at each of these, essentially if we have homeostasis starting here at number 1, so our blood calcium is kind of here. So if we're starting here, we have high calcium levels, so that calcium level gets a little high. We get some type of stimulus, so those receptors are going to recognize the high amounts of calcium. And then the effector response that it has, that calcitonin, our hormone over here, that calcitonin inhibits osteoclast, which is going to stop the release of bone from being broken down and calcium from being released. So the calcium goes up, calcitonin stops the osteoclast, which lowers calcium, and our homeostasis is restored. Well, if it keeps going and it decreases too far, then what's going to happen if our calcium is too low? Now again, the receptors get activated, and now the parathyroid cells are going to release the PTH, the parathyroid hormone, and that activates the calcitrol, that vitamin D, in the kidneys. And then those two hormones, the PTH and calcitrol, stimulate the formation of osteoclast. So again, calcitonin decreases osteoclast. So we're not breaking down bone. The PTH and the calcitrol stimulates the osteoclast, so we get the breakdown of bone to release that calcium so it can be reabsorbed in the kidney, and then that uptake into the small intestine can occur as well. All right, now a couple conditions here are effects. So osteoporosis, as the name implies, porous bone. So the bone becomes porous and a loss of that matrix that occurs. So this makes bones much weaker. They can become deformed or even easily fractured. So especially like older individuals are more likely to have hip fractures, or if they fall, more likely to break something. So it's about 2.5 times more common in women. And this is due to especially during menopause and altering that estrogen So again, some of the things that control this are estrogen and testosterone. So in women, when the estrogen levels drop at menopause, now we have inadequate calcium intake as well. Also too little weight-bearing exercises. So just people being more sedentary also increases the chances of osteoporosis. So early diagnosis, it can't revert everything, but it can prevent further damage or further breakdown of the bone. A few different medicines that can be used, so biphosphonates, essentially hormone replacement for women if that's the cause of it. Some antibiotics can help, and also calcitonin replacement can help as well. And then what about the effects of aging on the skeletal system? So kind of related to osteoporosis too, but there are other impacts of the aging process. So that bone matrix starts to decrease as we age, so our bones become more brittle due to the lack of collagen. Also, less of that mineral, the inorganic hydroxyapatite, the calcium and phosphates. So that causes the bone mass to decrease. Spongy bone is actually lost first, and then the compact, so it becomes more hollow. Again, increased bone fractures as the bones start weakening, causing deformation, loss of height, so starting to limp over, kind of fall over, but also pain and stiffness in the bones that cause stooped posture and the loss of the teeth as they start having that support. And then the articular cartilage wears down, and that replacement rate decreases that can lead to arthritis as well.